I'm going to start on this slide about two types of genetic mutations. Cancer cells turn regular cells into cancer cells when they're exposed to some kind of a mutation. Some of those are inherited, so that will be generational, such as breast cancer, passing those BRCA genes and the HER2 genes and things back into generations. Really, only 5 to 10% of these are affected by genetics. Acquired is when we are exposed to things in our environment, such as smoking causing lung cancer, alcoholism causing liver cancer, those kind of things. There are three types of carcinogens that we're going to talk about. So, of course, chemicals. This is multiple exposures over time. So this would be, again, smoking, being a 20-pack a year smoker, something like that, or exposed to things at the workplace that they ingest or they breathe into their lungs or something like that. Radiation damages the DNA as well. Example of that, atomic bomb explosions in Hiroshima. Radiologists actually have an increased risk of bone cancer because they are exposed to the radiation. And of course, we know that the beautiful sun causes skin cancer and melanomas with the ultraviolet radiation. Some viruses also can cause liver cancer. As I said, liver cancer can be caused by hepatitis B, and cervical cancer is linked to the human papilloma virus, which is the virus that causes warts. Oops. Skip one. Role of the immune system. The immune system's job is to watch and sit and be a sentry in all of our cells and in our lymph system and watch for things that are abnormal or watch for something that they know is a mutant or something bad for the body. So we have cytotoxic T cells. These kill the tumor cells directly, and they do that by producing cytokines. So these cells go directly after the mutant and surround it and destroy it and get rid of it. We have natural killer cells, and these are activated macrophages that actually go in also and destroy and lyse the tumor cells. The immune system also can produce B cell antibodies that will bind to the tumor cells and basically starve them, and they will die as well. Oncofetal antigens, these are some things that are found on the tumor cell surfaces, not well understood, and may result as cell regains its capability to differentiate into many different kinds of cells. So embryonic capability, they're talking about stem cells here. We're born with stem cells. Stem cells are the building blocks of our whole body. They can go anywhere and turn into any kind of cell that we need them to be. Examples of some of these antigens, and these are things that we would see in a serum lab test. If a physician was looking for an ovarian carcinoma, it would order a CA-125 level, CA-19-9, pancreatic and gallbladder, PSA, prostate screening. That's not it. You know what I mean, prostate cancer. And some of these are the breast cancer genes, KRAS, colon cancer oncogenes, and EGFR, lung cancer. So sometimes without thorough diagnosis or diagnostics, we can determine if a person has a risk or has developed cancer based on a lab test. Tumors are classified by their anatomic site, by their histology, which grades their severity, and also extent of their disease, and that is done with staging. This classification system is international. It gives the healthcare team an idea of what you're looking at just by the numbers. They use this to prepare a treatment plan, determine the prognosis, and compare groups statistically. So standardized vocabulary for everyone to understand on the team. They can compare groups with like or same diagnosis of people too to determine things. There are 4 grades of abnormal cells. Grade 1 as listed here, grade 2, grade 3, and grade 4. Also, and as you know, grade 4 would be the worst case scenario. The cells are undifferentiated, which when they say that cells are poorly differentiated, that means that the tumor cells are abnormal. If it is well differentiated, that means that the tumor cells look like normal tissue. So clinical stages. A stage of 0 means that the cancer is in situ, and that means there is no cancer. There are only abnormal cells with the potential to become cancer. In situ means in place. Stage 1, the tumor is limited to tissue of origin, very localized. Cancer is small, only 1 inch in area, and this is what you would call, quote unquote, early stage cancer. Stage 2, larger cancer and has spread to local tissue or local lymph nodes. Stage 3, extensive local and regional spread, and stage 4 is advanced cancer, and that means there is metastasis. The TNM system, classification system, looks to classify these tumors by tumor size and invasiveness, which is the T, spread to the lymph nodes, which is the M, and metastasis. So T describes the primary tumor site and size. N describes regional lymph node involvement, and M determines there is the presence of metastatic spread. Objectives of staging, it helps to plan for the treatment. It provides an indicator of prognosis. It assists to evaluate the treatment results, and they use it also for research. Here are the 7 warning signs of cancer. This is an acronym. C is for change in your bowel or bladder habits. This is what we see really most commonly with colon cancer. A stands for a sore that will not heal, so that would be more related maybe to a melanoma. U is unusual bleeding or discharge from any body orifice. And this comes to mind with women who are menopausal and begin to have vaginal bleeding again. That is an ominous sign, and that is typically related to ovarian cancer. T is for thickening of a lump in the breast or elsewhere. I, indigestion or difficulty in swallowing if they have a GI tract cancer or maybe esophageal or something like that, that they have difficulty swallowing and don't feel like the food will go all the way down. O is for an obvious change in a wart or a mole, so we're looking for irregular edges, changing color, maybe becoming bumpier, something like that, and a nagging cough or hoarseness. That is typically related to a lung cancer, and that is an early sign. So when our patients are diagnosed with cancer, of course, they're scared to death. Cancer treatments have come a long way since, 10, 15, 20 years ago, but it still brings on fear and anxiety, and the fear, of course, of death or being in pain or not being able to care for themselves and not being around for the family. So as a nurse, we should always be therapeutic listening. Sometimes we just need to listen and not offer solutions or anything like that. Most time patients just want somebody to talk to and listen to them. We need to figure out how to manage our own discomfort, because all of us have somebody in our family who has died from cancer, and we can, get emotional, which is not a bad thing, with the patient, but we need to try to be strong for the patient as well. We find that we may have to give explanations over and over because they're in shock or they're not ready to grasp it. Diagnosis of cancer. The diagnostic plan will include the health history, and that would be the history of present illness. Some people are notified of a potential cancer diagnosis from a pre-screening lab or a test, for example, the PSA or a mammogram. And some will present first with their abnormal symptoms, and then they get diagnosed from there. Also, identification of risk factors. Of course, it's family history, smoking, alcohol, what do they do for a living, exposure to radiation, and also recreational drugs. They'll get a physical examination that will be the baseline. Some specific diagnostic tests, example, cervical cancer, of course, is the pap smear, mammogram for breast cancer, PSA for prostate cancer, colonoscopy for colon cancer, those tumor markers, which are those labs that a few slides back, CA125, those things, and genetic markers as well if they think it's genetic. They can also do cytology studies. So, and example, of course, the pap smears. We see this a lot with bronchial washings. If they think that there's a lung cancer or a tumor, they can do a bronchoscopy, go down into the respiratory system, do some lavage, maybe capture a mucus plug, but also take biopsies of the tissue and of the tumor if they can get to it to see, so they can grade it and get the histology. Chest x-rays, these could be just baseline that they do, or ordered, of course, for any kind of a problem. CBC chemistry profiles, these will also be done as a baseline. They are not diagnostic for cancer. It's just a baseline of where did we start before we start the treatment, because a lot of the treatments will affect the CBC. Of the liver function studies, of course, the liver profile, AST, ALT, ALKP, and total bili. Several of the chemotherapies will affect the liver, and it will actually put their treatment on hold if their liver enzymes are elevated. And endoscopic exams such as colonoscopy and EGDs. More studies, of course, are dependent on the site. Radiographic studies, ultrasounds are common, CAT scans, MRIs, some radioisotope scans. This will be nuclear medication, and they will inject the patient with an radioisotope, and then they will take images to see for hotspots, similar to what a PET scan is, which is next. They're looking for metastasis or an increased uptake of this radioisotope, so they can narrow it down to what area it is. Again, tumor markers, here are a few more that are common. CEA is carcinoembryonic antigen, and that will help detect colon cancer, rectal cancer, ovarian, lung. AFP is alpha-fetoprotein, and that can detect cancers of the liver and the kidney. And we talked about CA125 and CA119. These tumor markers are substances made by the cancer cells themselves in response to the cancer in the body. Other things they can do is the molecular receptor status. This is typically done for breast cancer. They're looking also, it could be other cancers too that are estrogen and progesterone positive, mostly breast, ovarian, and uterine. They can find testosterone levels for prostate cancer. These diagnostic studies all help to guide the treatment, to make sure that the patient is on the right type of medications based on whether it is estrogen receptive or progesterone receptive. If the cancer is hormonal, if the hormone receptor is positive, then certain medications can be given to slow or even stop the cell growth. Hormone receptor negative, not as good as an outcome or prognosis. That means that hormone therapy was not likely to work for that typical cancer. So bone marrow biopsies, this is something that is used to diagnose leukemia, lymphoma, anemia, and also pancytopenia, which is a medical term that means that all cell levels are low. And of course biopsies, removal of a sample of the tissue, so they can do histologic studies of that. And this is just more, they can do needle biopsies or an aspiration. They can do incisional procedures to get the sample out. They have percutaneous, which is through the skin, and that is typically done with a biopsy of the kidney and the breast. Incisional is a partial excision, like a punch biopsy, or just a piece through the dermis of the skin. And excisional is removing the entire lesion, node, or mass. Health promotion and detection and prevention, recommended cancer screenings, practice self-examination. That's not just for women, it's also for men. Men also have a risk of developing breast cancer, and also men should be doing testicular exams to detect testicular cancer. They should know the 7 warning signs of cancer, the acronym for cancer, or for caution rather, and seek medical care if cancer is suspected. Most cancers, unfortunately, don't have any early symptoms. Some of those things that could be early symptoms for colon cancer would be pencil thin or ribbon-like stools, and that is usually from the stool is trying to slip past the tumor that is in the colon. Having continuous diarrhea, or of course having blood in your stool. And this could be, frank blood, which is bright red, or this could be dark tarry stools, which is digested blood. Pain is usually a very late sign for cancer, and it happens as the tumor or the mass puts pressure on the surrounding areas. Sometimes they will have persistent headaches or present with seizures if they have brain cancer. A lot of back pain can also indicate there's metastasis to the bone. Also, skin changes, sores that won't heal, unexplained anemia, unexplained weight loss. For bladder or prostate cancer, they will see change in their urination amounts and the flow, have dysuria, which is painful urination, and hematuria, which may be microscopic. Other symptoms are fatigue, extreme tiredness that doesn't get better with rest, and this is an important symptom as cancer grows or during early stage leukemia diagnoses. Fevers are an early sign of leukemia or lymphoma, as it does directly affect the immune system. Persistent cough or hemoptysis, which is coughing up blood, that could be lung, head, or neck cancers. And as I talked about before, hoarseness for more than 3 to 4 weeks could be esophageal cancer or lung cancer. Again, lifestyle habits, all of these things, you can read that. Some of the things, avoid, wear sunscreen, avoid people who smoke, and they should be encouraged to quit smoking. Eating a diet with fresh fruits and vegetables, whole grains and fibers, and decreasing dietary fat, and also foods that are preserved, such as processed meats, because a lot of times they're preserved with nitrites. Alcohol consumption is bad and can cause cancer. It breaks down into a chemical called acetaldehyde. This damages their DNA, which causes a mutation in the DNA and causes those cells to turn into cancerous cells. Also, maintain a healthy weight, get adequate rest, drink plenty of fluids, and have regular health examinations for early detection. So, collaborative care, the goal of treatment, of course, there are 3. There may be a cure, you may control the growth and the symptoms, and then there's palliation, which is being comfortable at the end of the disease process. For cure lengths, they are different for each type of cancer. We hear the magic number of 5 years. If you don't have a recurrence in 5 years, then they consider you're in remission or that your cancer has been cured. We know that that's not 100% true all of the times. Control, getting the cancer to respond to the anti-cancer therapies, treatment, and then maintenance therapy. We see this a lot with breast cancer. They get rid of the breast cancer and then they will be on Taxol or some other medication for 5 years, 5 to 10 years. There's also surveillance in the control, every 6 months getting a CAT scan, every 6 months getting CAT scans or MRIs until you get to the 5-year mark. And palliation is treatment aimed at providing relief of symptoms or to improve the quality of life. Factors that determine the therapy, they're going to look at the cell type, where the tumor is, how extensive is it, has it progressed, what is the physiologic and psychologic status of the patient, and most importantly, what is it that they want. So for cell type, some cancers are much more aggressive and will require aggressive treatment. Examples, small cell lung CA or oat cell lung CA is very aggressive and very difficult to treat. Location and size of the tumor, sometimes radiation is done first to shrink the size of the tumor if they have to have it surgically removed, or just shrink it smaller, which will mean a lesser dose of the chemotherapy drugs. Extent of disease is what we talk about when we say staging, and the patient's personal status and expressing their needs. Do they want treatment? They need to know the whole picture, what it will entail to the best of our knowledge, and then we ask them if that's what they want. And we also need to bring up resuscitation. Do you want to be a full code? Do you want to allow a natural death but still treat your symptoms or your cancer? So all that has to be talked about before it begins. So curative therapy, sometimes it is surgery alone. This is the treatment is offered, then is expected to have the greatest chance of eradicating the disease. May include surgery, radiation, chemotherapy, hormonal therapy, targeted therapy. Examples of curative therapy such as basal cell carcinoma of the skin, surgical removal of the lesion, and several weeks of radiation. Some acute leukemias, patients will have chemotherapy oral for months or years. Example, testicular cancer can also be cured with, if caught early, a combination of surgery, chemo, and radiation. Control is the goal of treatment for many cancers that cannot be completely eradicated, but are responsive to some of the anti-cancer therapies, and they can be maintained for long periods of time with therapy. Examples of control treatment, multiple myeloma and chronic lymphocytic leukemia. Pretty much covered that already with surgery and palliation. So for surgical treatment, if you cure and control, they will usually, most of the time when I think of this, I think about someone who has a brain tumor, and they will do surgery that is called debulking the tumor, where they go in and take as much of that area out as they possibly can, but sparing any nerve roots or any areas that they cannot risk having being destroyed by the surgery. This can also increase their chance that radiation or chemotherapy will reach those cancer cells. Surgery, supportive or palliative care when cure or control is not possible. These are some examples if the patient wants this or the family wants this for the patient. Insertion of a gastric feeding tube, so this would be a PEG tube. Percutaneous endoscopic gastrostomy. Placement of a CBL a central venous access device for the chemotherapy. We can also, draw blood from that. We can give blood if they need it. It's the fancy triple lumen catheter that they typically put in the jugular or in the subclavian vein. Sometimes they'll do prophylactic surgery, fixation of bones, so they don't have pathological fractures, because cancer also will degrade the bone, and it will make the bones weaker, and patients will have, it also pulls some of their calcium out, and they are at a risk of pathologic fracture. And because there are so many, there's no reason to teach you all about all of them, all for every person. So chemotherapy also is good to kill the cancer, but it's also very damaging to the normal cells as well. The side effects that people have from chemotherapy are most of the time caused by the destruction of the normal cells. General and drug-specific adverse effects are classified as acute, delayed, and chronic. Acute toxicity occurs during and immediately after the drug is administered and includes an anaphylactic or a hypersensitive reaction. They can also have extravasation, which there is tissue necrosis at that area, or a flare reaction. Many times anticipatory nausea and vomiting, and also some cardiac dysrhythmias. Delayed effects are, there's a lot of them, most prominently nausea and vomiting, mucositis or stomatitis, which is inflammation of the inside of the mouth, alopecia, which is losing their hair, crazy skin rashes, bone marrow suppression, which typically that is something that we call a dose-limiting effect of the chemotherapy meds. They have to look and see how damaging and how low the cell counts are. And those are reasons why sometimes people have to stop their chemotherapy treatment. Alterations in their GI tract, diarrhea, constipation, lots of things like that. Chronic toxicities is damage to the organs such as heart, liver, kidneys, and lungs. They can be long-term, or they can develop and disappear immediately. Some side effects that fall into more than one category are nausea and vomiting. That's a very common symptom for people with chemo. Sorry, I lost my place there. So intracavitary would involve intravesical, which is into the bladder, intraperitoneal. This is used to treat peritoneal metastasis. They inject the chemo and it dwells in the peritoneal cavity. There's also intrapleural, used for lung or breast. Intrathecal is a lumbar puncture with injection of the chemo into the subarachnoid space. And that also sometimes gets into intraventricular. And intraarterial is actually injecting the chemotherapy through the arteries that are supplying the blood supply to the tumor to choke it off. Okay, I think we talked about that already. The good thing about regional administration is because it is directly injected into the tumor site, but they can also use higher concentrations of the drug and have less problems with systemic toxicity. Okay, I talked about this one, talked about that one. Okay, preparation and handling of chemo, have to be very careful with chemotherapy. It could cause you an occupational hazard problem. In the hospital settings, only nurses who work on the oncology floor are qualified to administer chemotherapy. Like, you would never get pulled to an oncology floor and have to give chemo. They are monitored very frequently. Their labs, those kind of things, and they're also certified most of the time to give those chemotherapy meds. So you will not ever even give a chemotherapy oral med. It has even come to include that we would have to call the oncology nurse to come and give like a methotrexate by mouth, or even a Megase by mouth, which is just an appetite, increases your appetite, but it is considered a chemotherapy drug. There may be some risk in handling the body fluids and excretions of those patients who have been receiving chemotherapy immediately and up to 48 hours. So chemotherapy precautions, 48 hours after therapy, you must wear gloves, of course, flush the toilet twice if you're using that to get rid of waste, double bag clothing and their linens. And at home, they should also be taught to follow some precautions to double wash their linens and clothing in hot water. Dosages are calculated according to their body surface area, so this could change from week to week when they're giving their chemotherapy. They're also doing risk versus benefit when they're looking at the type of medications that they want to give to patients. You know, is there a bone marrow suppression? Check. We won't be able to give this drug. You know, are they anemic? Check. We can't give this drug. Their liver enzymes are up. We're going to have to wait and delay treatment a few days until those things resolved. So this part is going to talk about pharmacology treatment of cancer. These are what we call the anti-neoplastics, and this is Latin for inhibiting the development of tumors. There are two types of anti-neoplastics, cell cycle nonspecific and cell cycle specific. So you don't need to know this specifically, but the cell cycle specific is cytotoxic during a very specific phase in the cell, of the cell phases. Nonspecific is during any phase in the cell cycle. So these are side effects of the chemotherapy drugs: hair loss or alopecia, nausea, vomiting, diarrhea, mucositis or stomatitis, that bone marrow suppression or toxicity. This is where I talked about the dose-limiting adverse effects typically occur with the GI tract and the bone marrow. Some of these drugs are graded by their emetic potential, which is how likely are they to cause nausea and vomiting in the patient. Myelosuppression, that is bone marrow suppression, that affects our white blood cells, our red blood cells, and our platelets. And extravasation is the unintended leakage of a chemotherapy drug into surrounding tissues outside of the IV line, and this would be cause tissue necrosis. This would be an emergency. We have to stop it right away and do some treatment. So nursing process for clients, of course, we do an assessment. We do a thorough physical assessment, and after that we could do a focused assessment on whichever area has been affected. Looking at their past and present medical history, what kind of risk factors have they had, what kind of medications are they on, allergies. We need a baseline height and weight. We also need to talk to them about other things, such as, you know, what is their religion, how emotional are they about this, do they have financial concerns, do they need us to know something about their culture or spirituality. And also, of course, baseline vital signs and a full pain assessment. Special areas of assessment are going to come with nutritional status, the integrity of the oral mucosa in their mouth, are they having elimination problems, and what is their hydration status. These are just some nursing diagnoses related to chemo. Implementing, of course, we need to help to reduce fear and anxiety in the patient. Doing that passive listening, providing answers or getting the physician to come back, giving them a pad and pencil so they can write down their questions, because, you know, when the doctor comes in, sometimes it's just so fast and they're so flustered and they forget to ask what they want to ask, and then it's a full 24 hours before they may see the doctor again. Also, we work to build a trusting relationship with the client, and that means that we tell them the truth. If it's going to hurt, we tell them it's going to hurt. If we tell them it's going to burn, then we tell them it's going to burn. We want them to form not a bond with us, but that they trust us. Teach relaxation techniques. This could be guided imagery. It could be singing a song or music, or having a mantra in their head, that they could say, I'm going to beat this, I'm going to beat this, over and over for positive reinforcement. And then we also need to bring in the ancillary personnel, case managers, social services. They can help with financial issues. They can help the patient maybe sign up for Medicaid or some concerns that they have with their Medicare. That's what these people are, one of the main things that they do on the floor. Management of stomatitis. We need to give good oral care. We want to avoid those lemon swabs or glycerin, anything containing alcohol, because that is going to hurt. They usually have some open sores and ulcerations in their mouth. We need to get them a soft bristled toothbrush. Keep their lips moist. That could be, chapstick, Blistex, ice cubes, ice chips. A lot of people like to chew on ice chips. And avoiding spicy, acidic, hot foods, so we can help them with their meal tray to get some things that would be more comfortable for them. Also, we can give nystatin swish and swallow, which is a really disgusting sweet cherry flavor, to work on the stomatitis, and the candidiasis usually happens. And viscous lidocaine is kind of a thick, gelish stuff that they can swish and swallow in their mouth, and it will numb the inside of their mouth. And a lot of times you need to time that so we can get that in there to them before their food tray comes, so they're able to eat and take some nutrition. How to manage nausea and vomiting. Getting anything that smells bad or noxious or looks bad, taking the urinal with urine off of the bedside table is always a good idea. Making sure that when we bring their food tray in, that there's nothing on there that is offensive to them and may trigger them to vomit. Offering oral hygiene. Restricting their oral fluids when they're nauseated. They will be having some IV fluids running, so we won't have to be terribly concerned about them being dehydrated, because we will be supplementing them with IV fluid. But we need to restrict oral fluids when they're nauseated, because all that acid coming up your throat and into your mouth is just going to exacerbate their symptoms. Also, just like the COPDers, they don't have a lot of energy, so we would offer small, frequent meals, maybe 6 a day. Encourage some of those boost drinks or Ensure drinks, making a milkshake with some of those things. A lot of people like to do that, and also definitely if giving a can of Boost or Ensure is putting it on ice. It makes it a little bit more palatable. Clear liquids in a bland diet to not aggravate their mouth. And offering, sometimes antiemetic meds are given around the clock, and they're scheduled in the MAR, so they don't be less likely to have nausea and vomiting. Management of diarrhea. Guests watch what they're putting in. We can consult the dietitian so they can come in and talk to them about the things they like to eat, and also explain to them why maybe some of the foods they like to eat is not going to be agreeable. And also anti-diarrheal meds. Again, sometimes these are offered around the clock. Management of nutritional concerns. Dietary will come in, or the dietitian do a 24-hour dietary recall just to determine what the client normally eats, what they like to eat. The nurse will control the antiemetics and the pain management. We can delegate oral care to the patient care tech, and informing them that really needs to be done every 2 hours or more if the patient wants it. Hydration, and also encouraging foods that are high in protein, such as chicken, turkey, cheese, Greek yogurts. If they're not going to eat very much, what they do eat, we want it to be worth it. We want it to have enough protein in there so they can fight the disease and also get stronger and heal. Avoid metal utensils. Some of the chemotherapy meds will give them a real metallic taste in their mouth, so we would give them plastic silverware. Gelatins, puddings, and milkshakes are always a hit. These drinks or shakes I talked about, energy conservation, and those appetite stimulants such as Megace. Management of alopecia. Again, we need to be verbal with the patients, get them to talk about their fears and the anxieties that they have relating to hair loss, early preparation before hair loss occurs. I have a friend who is battling breast cancer right now, and her hair started to fall out a little bit, and she just went ahead and shaved her whole head off. She said that, cancer wasn't going to take that away from her, so she shaved her hair, and she has lots of cute wigs and lots of cute hats. So there are lots of things that, we can do to camouflage it for them. Management of bone marrow suppression. As I said, this is one of the dose-limiting side effects of the chemotherapy medications. They will present with anemia, which, remember, anemia is not a disease. It is a symptom of another problem. So if the patients are anemic, the red blood cells are low, the hemoglobin hematocrit are low, they may need a blood transfusion. They may get some iron preparation. Most commonly, they're going to get epigen or erythropoietin, which is a natural hormone that is made by the kidneys that increases production of red blood cells. They may also have leukopenia or neutropenia, which is low white counts and low neutrophils. So all of these things together really puts them at an increased risk of infection. So we need to teach the family and the client, do good hand washing technique. We need to monitor their temp, every 4 hours for fever. So you need to delegate that to your patient care tech and then instruct them. I want you to notify me if the temperature is greater than 100.5. That way everybody's on the same page. And also avoiding sick people. Of course, you're going to see sick people in the hospital. But as nurses, we can control the visitors that come in. So if somebody comes in and they absolutely, don't want to leave and it's not such a huge big deal, we can request that that family member put on a mask. Or at the very least, we can put a mask on the patient so they are not exposed. But it's best if we tell the patient, explain to the patient why they're at a risk, and so they can tell their family, don't bring, little Sally here to visit me. She's got a runny nose and all that stuff. So some medications to treat leukopenia or neutropenia that we're going to be tested on are filgrastim and pegfilgrastim. This is Neulasta and just escaped me. Also, we need to make sure that there's a low microbe environment. So we can control this by not allowing real plants with real soil for the patient's families to bring or visitors to bring those in. Doesn't mean we can't keep them. It means that we might put them at the nurse's station. Also, they need to be sure that they wash the fruits and vegetables because some of them could have pesticides or something, microbials, that could really not be good for them. Encouraging good pulmonary hygiene and oral care. Thrombocytopenia, that's a low platelet count, so we need to avoid injections. Your patients will not be getting IMs. If we're doing finger sticks, that's a very small needle. That wouldn't really count as an injection, but we do also need to monitor that and watch for overt and covert signs of bleeding. For those people who are still concerned about the reproduction, chemotherapy does put a risk for damage to the testes and the ovaries. It can cause teratogenesis to a fetus, which, birth defects, or the fetus will not survive. Also, there's a risk for sterility, so there's a lot of conversations about that. Do they want to bank their sperm? Do they want to bank their eggs? Because it's not recommended that you conceive a child after having chemotherapy due to potential birth defects. Encourage contraception during the treatment, and also teach the patient up to 8 weeks after their treatment is completed. We're going to monitor for therapeutic responses in our evaluation component. Is their appetite improved? What kind of side effects are they still suffering from, and how can we help to alleviate that. Is their comfort, are they more comfortable? Is their energy level better? Have we seen an improvement in their quality of life? Are their lab values better? Special care when administering vesicant drugs. These are medications that are toxic, that cause a high risk of extravasation. These drugs are not being tested on the exam, but a common one is vincristine and doxorubicin. These medications are always mixed in the pharmacy. They use a laminar airflow hood and really big on personal protective equipment when they're doing that. They don't want that to risk getting out into the air. But for the nurse, we need to monitor that IV site and that infusion every hour to make sure it has not leaked into the tissue or infiltrated. So we also need to know the antidotes when we're nurses at the bedside to treat if there's a potential extravasation.